It's just much thinner. And so very good prediction of fractures from just osteoporosis by using bone mineral density. Bisphosphonates and denosumab and teriparatide reestablish the vertical trabeculation, so they fill in the holes in the bone that osteoporosis causes. But when the bisphosphonates and denosumab fill the holes, they also inhibit bone building. And that's one of the big problems we have now with bone suppression. People on bisphosphonates for a long time have bone suppression. So they inhibit osteoclasts a lot more than osteoblasts. But they still do inhibit the osteoblasts, or bone building, to an extent. Let's look first at who to screen and how to screen. Who to screen? Again, new in March, the NOF has come out with what look very much like the old guidelines. So women age 65 or older. The Endocrine Society gets men in there. I know this is a women's health conference, but I'm going to stray over the line occasionally. Men 70 years or older. Anybody between 50 and 69 with clinical risk factors. And this year, not only do they have rheumatoid arthritis, steroid use, they also have added malabsorption. So if your patient has had a gastric bypass, I'm going to talk about later in the morning, a gastric bypass, any kind of inflammatory bowel disease, any type of malabsorption, you're going to want to screen them as they get to be over the age of 50. Anybody who is 50 or older with a fragility fracture should be screened. Menopausal women, they say you need to use FRAX. And if they have an osteoporosis risk factor, 10-year risk of 9.3%, you ought to screen them as well. But you don't need to screen every postmenopausal woman. You still can. In most states, the insurance companies are still going to pay for you to screen postmenopausal women, but they're clamping down on that because the U.S. Preventive Health Task Force says it's not necessary if women do not have risk factors. And what is a FRAX of 9.3? It's about the average 65-year-old woman's risk. So they're saying, again, move out a little further. You don't have to screen people at menopause unless they are at risk. And women 65 years of age or older with fractures, the NCQA is telling insurance companies they're going to be dinged if these people are not screened. So the important point about this one is that insurance companies are beginning to go out and order DEXA scans on people whose lives they cover. And you'll want to check with your insurance carrier, because I know we set this up for our insurance carrier, which is a large health plan, but we notify the primary care provider when the patient has had a fracture and a DEXA scan. Some insurance companies don't notify you, so you may want to check and make sure that if your patients are getting these, you're getting the results. The National Osteoporosis Foundation also said we should do vertebral imaging, and that's been controversial for a while, but you want to just get a vertebral film on some of these people. And there's a long laundry list here. You may not want to do this on everyone, but basically they're saying 2/3 of the vertebral fractures are missed. We don't know about them. And I'm a little skeptical about 2/3, but the other day I had a lady come to my office and I said, have you ever had any fractures? And she said, no. And I don't want to take anything because I have osteoporosis, but I've never had a fracture. Well, she had a CT, an MR of the abdomen, and I said, well, let's just take a quick look here. And I just skimmed through it, and she had a giant compression fracture at L3 that she didn't know about, and the radiologist had tucked down in the bottom because he was looking for slipped discs. So again, imaging these people may be important. So women age 65 to 69 and men age 70 to 79 with a T-score of -1.5 on their DEXA. Men and women who lose height, considerable amount of height, 2 centimeters or more, may have had a fracture. And if they're 70 to 80 and have a T-score of less than -1, remember -1 down to -1 is normal, you may want to take just a quick picture. You don't have to take an MRI, but just take a picture of the vertebra. Okay, so how to screen? The DEXA scan does a really good job for us. It makes the diagnosis, because we said osteoporosis is reflected in bone mineral density. And you want to look at the patient's picture if you possibly can and use the lowest T-score to make your diagnosis. The DEXA also helps us monitor effectiveness, and that's what most of us use it for most of the time. Or maybe you guys who are screening in GYN use it more for diagnosis, but I use it more for effectiveness. And you can repeat it at 1 to 2 year intervals depending upon the insurance company, and you're going to monitor that by looking at the bone mineral density, not the T-score. And we're going to see that in a minute, urging you to look at the picture of your patient rather than just the report. You can also predict the fracture risk at any site using the DEXA, but using FRAX works a lot better for most patients, so we'd advise that. Let's take a quick look at DEXA scans. I know most of you probably do this. How many of you read your own DEXAs? Okay, well, so some of you could probably help me out here. But anyway, this is the spine, and it should be straight. In addition to that, if we look at the young adult mean, the T-score is where your patient is compared to the young adult mean. It is the number of standard deviations, and these are standard deviations, above or below the young adult mean. And the Z-score is the number of standard deviations above or below the patient's age-matched mean. We use the Z-score for patients under the age of 50. If your patient is over the age of 50, we're going to use the T-score. And you can see that most people just follow this line. This is the age-related line. And if you don't take steroids, if you don't have rheumatoid arthritis and so on, you follow this line. And we'll see that that's important in a few minutes when we think about repeating the DEXA scan. So now we have a grip on what the DEXA scan is. And you say, well, I don't have time to look at the picture. How many of you get pictures back with your DEXA? Oh, good. If you don't, then you ought to get with your radiologist. If you have an electronic medical record, you can look in the PACS system. Almost all of them come with the PACS system, and you can click on that and get the picture. Very important to look at the picture, because although you'd like the spine to look like this, and you could read the report on this one, it said your patient is way above normal. The report on this next one coming up said, there's been a significant increase in bone mineral density over the last year. I wonder how we knew that. Well, actually, you can interpret this spine, and unfortunately, that's the spine that I usually see, because none of it is looking at you in the AP direction. It's all sort of crooked. So you really need to take a quick look at the picture and not tell Mrs. Jones that her improvement in bone mineral density was just fantastic in the spine. So most of us look at the hip, and particularly in patients over the age of 65, because there are osteophytes, there's arthritis, the spine is not as accurate. So take a look at the hip, and that's very easy to look at. The hip placement, this should be femur should be perpendicular. You should see a little piece of the lesser trochanter, and very important, the femoral neck box should be on the femoral neck. You say, of course. And the reason I want you to look at this picture and just look at that hip picture just a few seconds, you can easily see that here the femoral neck box is on the femoral neck. And here, it's not. And there's a big difference in your T-score, because here you're comparing soft tissue to bone, and here you're comparing soft tissue and bone to bone. So it's going to lower your T-score significantly if the femoral neck box is impinging upon the pelvis, or if it's slipped down like this one has upon the femur. So quick look at the picture really helps you and your patient make better decisions about the changes in their bone mineral density on the DEXA scan. By the way, if you have questions as we go along, I don't mind your asking. Okay, so think about poor neck box placement. Just a quick glance will tell you about that, and it's one of the main problems. Okay, so we use the DEXA to think about the WHO diagnostic characteristics, the WHO diagnosis of osteoporosis. So if you're -2.5 or less, you have osteoporosis. If you're -1 to -2.5, you have osteopenia, and down to -1, as you can see, you are normal. But what the DEXA does not do for us is look at bone strength. And we're seeing now that some diseases cause a considerable risk for fracture because of deteriorating bone strength, although the bone density is essentially okay. Also, it doesn't distinguish diseases. For example, this patient down here with a T-score of -3 could have osteomalacia or vitamin D deficiency with poor mineralization that is causing this DEXA to look as though they have osteoporosis. Remember, osteoporosis is a normal mineral to matrix ratio. So we need to look for other things. When I said that bone strength isn't recorded by the DEXA, then I think there are two very nice examples that have come out this year in the literature, and more is being known about them, so I think it's a good idea to talk about them for a couple of minutes. They're diabetes in bone, particularly type 2 diabetes. Remember, type 2 diabetes is an inflammatory disorder. It has glycation products. You get A1C as glycosylated hemoglobin. You get glycosylated bone proteins as well, glycosylated kidney proteins. And these can cause complications for the patient with diabetes. In type 2, hip fracture risk is increased by about 10 to 30% after you adjust for bone mineral density and the other classical risk factors. So just type 2 diabetes itself confers a significant increase in hip fracture risk. That's most significant where age is not the greatest factor. So in your younger patients, in your just perimenopausal and postmenopausal type 2 diabetic patients, there is a very significant relative risk increase of 6.2 in those patients. So that's a really striking increase. So if their T-scores are running in the -2 range, you may want to think about those people being at high risk for fracture. As age takes over and age becomes the most prominent risk for fracture, then the relative risk is only 2.22. But then again, those people with type 2 diabetes have much greater risk of hip fracture than the folks who do not have type 2 diabetes. So don't wait for the T-score in those folks to get to -2.5 before you treat. You want to just look at them as very high-risk patients. Now, what seems to be the problem, and this year people have made some great strides into figuring out what the problem is with type 2 diabetes. It's not a low bone mineral density, we know that. It's reduced tissue strength because the microarchitecture of bone, the collagen fibrils, are adequately mineralized, but the pattern is wrong. Your bone fibrils, your collagen, if you were, is sort of like a fingerprint. And this fingerprint is somewhat awry. So bone is easier to dent. And you don't want to sign up for this, but they're doing this by actually they have a machine that dents the bone, and it makes a big bruise where it dents it. They do the radius, they press on it, and they see how easy it is to make a little dent that persists for a time. So the elasticity of this bone is not good, and when you push on it, it doesn't return like most normal bone. Now, what does that mean clinically? Interestingly, the hemoglobin A1C correlates with the fracture risk. The higher the A1C, the higher the increase in fracture risk. I apologize for spelling glycation products incorrectly here. But they accumulate in the bone, so the bone structure is glycosylated. And remember that if your patient is using thiazolidine diones, they're at higher risk for fracture. It seems to make this problem worse when you use thiazolidine diones for a significant period of time. Metformin and insulin both stimulate osteoblast production. We don't know if that's going to make a real clinical difference, so that for now that's just known. Obstructive sleep apnea is the other thing we ought to talk about, because people with obstructive sleep apnea are 2.7 times more likely to develop osteoporosis. They remember that obstructive sleep apnea increases the inflammatory potential, and hypoxia increases the inflammatory potential in the body. Also, if their 25-hydroxyvitamin D levels are low, the risk goes up even more. So be sure and add those people to the list where you're going to measure 25-hydroxy-D levels. If they use CPAP and get at least 7 hours of sleep, there's one nice study showing that they have a over the years, lowering of that increased fracture risk. So you need to get these people to sleep with their CPAP. You need to think about them in your office. They have a higher risk. And if they are male, I know it's an aside here, but if they are male and they're young males, don't think about using testosterone to preserve bone mineral density, because that makes the sleep apnea worse. So you're going to think bisphosphonates first in those folks for preservation of bone mineral density. Dr. Martins is keeping track of how many times I mentioned men. He gives me a hard time about that. Okay, who to treat? Well, our goal is to prevent fractures in patients who have significant risk. It's not to increase the bone mineral density, because remember that bisphosphonates, even if they don't increase the bone mineral density a great deal, and raloxifene, which doesn't increase bone mineral density very much, both lower the risk of fractures. So, how are we going to decide who to treat? We're going to use FRAX. And remember, FRAX is taken from a worldwide database. It was very large, has a good predictive value. And what it does is to take the known classical risk factors to put them into an algorithm. And the biggest risk factor, particularly for women over age 65, is going to be age. But then, you remember, you see the steroid-induced problems, previous fractures, family history, smoking, rheumatoid arthritis. And a lot of people are ticking the rheumatoid arthritis click for type 2 diabetes. Now, again, that's not official, but it does help out there to give you a better thought about what the person with diabetes will have. Secondary osteoporosis, again, Cushing's syndrome, or hyperthyroidism, Paget's disease. But on the other hand, also people are using that for folks with early menopause. Again, not official, but it gives you a little leg up to help their score be more accurate. You may use this with or without the DEXA. And what you're looking for to treat, National Osteoporosis Foundation is telling us we're going to treat major osteoporotic fractures. If the 10-year risk is 20%, we're going to treat hip fracture if the 10-year risk is 3%. So, again, those are our cutoff points. And I hope you're all using FRAX, right? Yeah. It comes as a free app. And now, when I said that, everybody's looking at their phone. But okay, are there problems with FRAX? There are problems with any algorithm. It's excellent for women 60 plus, particularly if age is the only factor. But you can use it in patients who have the classical risk factors if you put them in correctly. It underestimates risk for the early postmenopausal woman. It doesn't estimate correctly the risk for type 2 diabetes or sleep apnea. And in the United States, we feel that it is not accurate if the patient has been on bisphosphonates, if they've been on bone-active agents, because we've changed the risk, right? We hope. We're prescribing all these, so we change the risk. So we don't think it's accurate. In the United Kingdom, they use it after drug holidays to see if you're going to be able to get back on bisphosphonates. That's a little iffy. We don't know if we believe that in the United States yet. Okay, people always ask me, when do I get this DEXA scan again? We said if you're looking at efficacy of therapy, if you're looking how Mrs. Jones did on her bisphosphonate, you can get it in 1 to 2 years. Most scanners takes about 2 years to get a larger change than the error in the scanner, as we'll see in the cases. But this is an algorithm you can kind of use if you know that this is a 65-year-old plus woman, and they lose bone mineral density about 1% a year. Age is the only factor. This doesn't work for people on glucocorticoids or have rheumatoid arthritis. But if age is the only factor, you can kind of take a look at this, and your patient didn't need therapy. You said, okay, Mrs. Schmedlap, you're doing pretty well. We don't need to treat you this year with a bone-active agent. When are we going to check again? So this is to decide when your osteopenic patient has had enough bone loss. Insurance companies are a little iffy about this one. Some of them say 2 years, some of them say 5 years, and there's no real evidence base. But these people took what we have, and they told us that if we know that age is the main risk factor, so they don't have glucocorticoids, smoking, etc., then we can estimate the time to a new DEXA by looking at the initial bone mineral density and T-score and the 10-year FRAX score risk. Remember, we're going to treat at 3%. So we look at where Mrs. Schmedlap is this year. We can estimate the time it's going to take her to get to a T-score of 3%. So this is fairly decent algorithm. Your T-score is -1 to -1.5, and your FRAX is 1, then you could repeat it in 10 years. But the people we want to know about, your T-score is -2 or lower, and your FRAX score is greater than 2, you can tell the insurance company it's not 5 years. We know that this lady is going to reach 3, a FRAX score of 3 at the hip, and where we're going to treat. in about 1 to 2 years on average if you don't give her steroids and she doesn't develop any other risk factors. So you can tell him, I need this DEXA in 1 year to 2 years because she's going to get there. So that gives you a little more ammunition when you're dealing with the insurance company, and also gives you a thought about how rapidly your patient is going to progress to significant osteoporosis that you're going to treat. Who to treat? This is the same as last year, so we won't spend any time on it. Essentially, it's men and women over age 50, T-score of minus 2.5, T-score of less than 2.5, but secondary causes like glucocorticoids. Remember, if your patient's on steroids, you're going to treat if the T-score is less than minus 1. So you're not going to wait till they're minus 2.5. You're going to treat when they begin to lose bone. Okay, how are we going to treat? Well, remember that the Nurses' Health Study showed that even people who took more than 1,000 milligrams of calcium didn't have any correlation with cardiovascular risk. WHI, again, 1,000 milligrams of calcium and 400 of D, no increase in cardiovascular events. But there have been some large database looks that suggested that calcium supplement, particularly in men, caused heart disease or was correlated with heart disease. But this year, a really great study, I mean, this is a meta-analysis looking at cardiovascular events and all-cause mortality in women over 60. There were a lot of things that came out of this study. But their analysis didn't suggest, and this is a huge database, that the average woman on the average dose of calcium supplement was going to have any cardiovascular events. Well, thank goodness. We can now tell people to take their calcium, right? It's, well, how much? The National Academy of Sciences says if you're pregnant, 1,300 milligrams. Men and women, any age basically, postmenopausal women, and they suggest men around 50 to 60, not much evidence in men, 1,200 milligrams a day. Remember, that's if your patient has normal renal function, and the Kidney Foundation says we should not give 1,200 milligrams a day to women who have abnormal renal function. If you have stage 3 renal disease, I don't want you on 1,200 milligrams of calcium, more like 1,000. If you have stage 4 renal disease, your nephrologist and I talk about what kind of calcium you're going to be on. Because as your renal function deteriorates, you don't clear calcium very well, and you don't clear phosphorus you don't clear a lot of things very well. But as it happens, you can get hypercalcemia if you're taking 1,200 milligrams of calcium, particularly if you become dehydrated. So again, if you're in good renal health, 1,200 milligrams a day doesn't seem to be a problem. Dietary calcium is best, and the NOF agrees with that. Because remember, the U.S. Preventive Health Task Force said that they don't want people who are postmenopausal and are healthy taking calcium supplements, that we shouldn't be recommending those to folks who are postmenopausal and healthy. And the NOF said that's fine, but postmenopausal and osteopenic or osteoporotic, we really need to think about those folks, and we need to recommend calcium to them. Dietary is best. And you can get in 1,200 milligrams of calcium with leafy green vegetables and dairy products. Okay, how about vitamin D? How much D? Well, the National Academy of Sciences says 600 IUs a day, or if you're over 71, 800 IUs a day. But most people think you probably need more than that, and it's difficult to obtain from dietary sources. You shouldn't let your patients take more than 4,000 international units a day unless you are treating them. If they have a deficiency, you can use what you like, but if they're just coming in and they're bringing their big sack of over-the-counter things, you're going to toady up. You don't want them to have more than 4,000 IUs a day. We know that vitamin D deficiency that is not good for you. You can develop osteomalacia, which increases your risk of fractures. And D therapy really is the cure in D-deficient patients. But then, what do we know? Well, there's a big controversy about what is deficiency. If you look here, anyone will agree that under 20 nanograms per mil is a D deficiency, and we ought to treat that. But between 20 and 30 is insufficiency, and then 30 to 60 is okay. But look what happens between 20 and 30. The parathyroid hormone is elevated, and that causes you to lose hip bone mineral density. But only 3% of the population has an elevated PTH between 20 and 30. And so are we going to treat them? Well, this year, the Institute of Medicine moved everything around and said, look, we're not going to treat these people between 20 and 30. It takes a lot of vitamin D, it takes a lot of work, it costs a lot of money. And so, and the NOF said, oh, wait a minute here. Well, if they have osteoporosis, maybe we think you should treat them. And the Endocrine Society said we should treat everybody between 20 and 30. So nobody knows at the moment, and there's not very much evidence. And they're all arguing about the D assay. Is it really good? Should we get a free D? Don't do that. Oh, expensive, expensive. So at any rate, you still screen with a 25-hydroxyvitamin D. It's the most long-lasting metabolite. Your lab is pretty good at it, particularly if you're doing serial determinations. And most people now are going to treat if you're less than 20 nanograms per mil. It's a judgment call treating these people between 20 and 30 if they have osteoporosis or Paget's disease or hyperparathyroidism or they're on steroids. Probably going to want to do it. Otherwise, your normal person that comes into the office with a 22 or a 26, probably not going to treat them. Your judgment call. There's the reference for you. Okay, who to screen for deficiency? Not going to spend much time on this because you can read as well as I can. If you have young people with fractures or low bone mineral densities, patients with congestive heart failure, patients with diabetes, type 2 diabetes, patients with rapid turnover states, obese people, okay, they don't convert as well to 25D. Malabsorption, we talked about. People with gastric bypass, almost all of them have osteopenia because of vitamin D deficiency. We're going to replace the D. Again, our goal now is going to be 20 according to the Institute of Medicine, 30 according to the Endocrine Society. And you're going to check the D, the 25D at 12 weeks. So you're going to give them whatever you choose, and most of us choose what Hollick decided in 1998, that we were going to use about 50,000 IUs of D2 because it's cheap and it works. We're going to give it for at least 12 weeks. Some people give it for 16. If you repeat the 25D at 12 weeks and it's still low, do it again. Some people don't have a good capacity to absorb D, but don't give up. You know, just get them at least to 20. If they're really obese, to maintain people between 20 and 30, you need about 50 IUs per keg per day. So if they weigh 250 pounds, your 50,000 once a week isn't going to do it. So think about those people, ratchet up the D, or keep them on the 50,000 for longer. Okay, so we'll take a look as we close up about the medications for osteoporosis. And we're not going to talk about raloxifene, basodoxifene, or calcitonin today, except calcitonin very briefly. We're going to spend most of our time on bisphosphonates, teriparatide, and denosumab. There's an FDA warning about calcitonin because of increased malignancy associated with it. If we look at the meta-analysis of 21 trials with over 10,000 patients, there was a 4.15% malignancy rate in the calcitonin-treated patients and a 2.9% malignancy rate in the placebo-treated patients. Whoa, relative risk of malignancy is increased. And we didn't know, it was kind of all sorts of malignancy. But this year there was last year there was a nice study showing that liver cancer is definitely increased in the troops. So the FDA said, the advisory committee told them to take it off the market, but the FDA looked at all of the formulations, looked at all of the data, and said that in order to use calcitonin, which is our bottom of the barrel medication anyway, you must discuss the malignancy risk. I mean, okay, Mrs. Schmidlap, going to give you this prescription for something that causes cancer, and it may help your bones, but it may not, and it doesn't prevent hip fracture. Uh-oh, you know, can you see yourself with that little scenario? And they say every year you need to reevaluate the people on calcitonin and see if they really need to be there. Remember, it only prevents spinal fracture. That's iffy at best. Alendronate, nothing new about alendronate. Long half-life in bone, 5 years or more, and still the most commonly used therapy for osteoporosis. Alendronate used to be Fosamax. Excellent. Decreases hip fracture, decreases spinal fracture, but the new prescribing instructions that were mandated by the FDA said that at 3 years and then at every year thereafter, we need to look at people, make sure they still need to be on the bisphosphonate. Resedronate is once a month. That's marketed as Actonel. The only really important thing about that is that bone turnover is back to normal in about a year, whereas alendronate stays in the bone for 5 to 7 years. The effect of the resedronate or Actonel is gone in a year. So if you have somebody want on and off and you want it out of their system, then this is the one to choose. Bandronate, 150 milligrams once a month, is generic. So some of your patients are going to want an inexpensive once-a-month medicine. You could use a bandronate. Zoledronic acid is our most potent bisphosphonate, and it is the most potent, not because it's any more potent than alendronate, but because you have to take alendronate by mouth once a week. And some of your patients, I hate to tell you this, don't take it every week. With the zoledronic acid, we put it in, it's there for a year. So it's going to be your most potent thought. Remember that you need to watch creatinine clearance in all these patients on bisphosphonate, but you really should not use zoledronic acid. The creatinine clearance is less than 35. We have a cutoff of 40 in our office because there have been reports of acute renal failure in patients who had a creatinine clearance of less than 40. And in fact, if you do the creatinine clearance, I wouldn't advise this, after the patient who is over the age of 65 has had zoledronic acid for a few days, it's going to be a little bit lower. So good hydration in these patients. If they come in and they haven't hydrated themselves well, we give them an extra 250 cc's IV if they don't have congestive failure. So we make sure they're well hydrated before we give this medication. How many of you use zoledronic acid in your office? Okay, nobody. Well, so you can send them to Mark or I. We're happy to do it. Remember that it's now generic, but the important thing is it has about a 3-year half-life in bone. But by the end of this 3 years, bone formation is reduced on average by 29% in virtually everyone who uses it. So bone building is definitely decreased by these. The FDA, this came out later, so the FDA made them look. So it is, bone building is decreased by these. How about denosumab, marketed as Prolia? Again, indications, postmenopausal osteoporosis, with high risk of fracture. This has more side effects. It's really easy to give in your office. How many of you give Prolia? Some of you. It's really easy to give. It comes in a pre-filled syringe, so it's really simple. It's just an injection, so that you can easily use this in your office. It's 60 milligrams sub-Q every 6 months. You need to monitor the calcium. You can cause seizures in people if their calcium isn't normal with either zoledronic acid or with denosumab or Prolia. And if they have renal insufficiency, good idea to monitor the magnesium as well. Remember, magnesium is necessary for the PTH to help mobilize calcium for the bone. So if you do lower it in the serum, when you give your injection, you really need a normal magnesium to pick up the slack from bone. It's contraindicated, of course, in hypocalcemia, pregnancy, and hypersensitivity, as are they all. Side effects. You have to talk to people about the Prolia side effects, and there's a new warning out. The FDA sent you a little thought about Prolia, and it can cause severe muscle and bone pain, just like bisphosphonates. It's an anti-resorptive agent. It can cause atraumatic fractures. It can cause osteonecrosis of the jaw. It has the same set of side effects. The potential for them may be a little less. It may be a little less likely to cause osteonecrosis of the bone or atraumatic fractures. There's 8 years of data out there, and there have been, in the study, no osteonecrosis or atraumatic fractures. You shouldn't use this in people with significant skin conditions, psoriasis, atopic eczema, other chronic skin conditions. So be careful of that. You can make psoriasis flare. Unfortunately, I saw a lady the other day who had that happen to her. She had the denosumab at another institution, came in, her psoriasis was just really had gone rampant overnight. So don't use it in folks with psoriasis. Check your that should say 25 hydroxy, probably, level before you give this. Bone pain is a lot less common in people with normal vitamin D levels. In the renal failure patient, you're going to have to check the 125, but in most of our patients, we can just check the 25. Okay, this is a nice thought from the ONJ people. They had a conference and they looked at it, and this is the world consensus on osteonecrosis of the jaw. In the osteoporosis population, 0.001% to 0.01% of people get it. The osteoporosis population included here the people who have significant risk factors, people on steroids, anti-resorptive agents, and cancer therapy. The people who are much more likely to get this are the people who are taking high-dose bisphosphonate, high-dose denosumab, either one, for cancer therapy. And so these were included with the troops. So if you look at the person with just osteoporosis, it was hard to do this from their data, but it looks as though it's about the same as the general population. So you're not going to give anyone osteonecrosis of the jaw, most likely, if they don't have risk factors. So look at the risk factors. In Texas, no one ever looks in the patient's mouth, but let me tell you, when you peer in there, bad teeth, bad gums. So what are they saying? They say for prevention of osteonecrosis, good oral hygiene. Have them go to the dentist and correct the dental disease before they start the therapy. But the interesting thing was the bottom one here. They said in patients at high risk, those are the people who have cancer doses, the people who take steroids, and so on. If they're going to have extensive dental surgery, are you going to stop it first? No. The dentist calls you and says, Mrs. Jones is going to have a filling. Should I stop her bisphosphonate? No. If she's going to have significant oral surgery, if she's going to have implants, then everybody, including the dentist, agreed you're going to stop this following extensive dental surgery and resume when the site has healed. That makes a lot of sense. Missing the bone for 7 years, you're going to stop it 6 weeks before you take out a tooth? I think it's still going to be there. So again, just think about osteonecrosis of the jaw, but don't lose sleep over it. Okay. So bisphosphonates work. Denosumab works. But the risk of hip fracture is really high without them. And with them, let me just go down to the bottom here, the risk of atypical fracture after 5 years is about 16 per 100,000. We only have one really good retrospective study. After 9 years, though, it goes up to 113 per 100,000. So we want to get people off their bisphosphonate. That's the only really good study. Maybe Mark has a better one, but this is the only really good, and it's retrospective. So what are the clues for us that people are getting problems with their bone from their bisphosphonates? What are the clues that they're getting into trouble on this bisphosphonate? Well, pain. And you say, oh, heck, all my patients have pain. They have arthritis. They are all achy. This is different. This is groin pain. It radiates down the inside of the front of the leg. It's hip pain. It's sometimes worse when they exercise, but so is arthritis. But this is a different place. It's frontal groin pain. So it's down the front, in the side. If they have that, get an x-ray, write on it bisphosphonate. You can write anything to let the radiologist know, and they will take a look. Because we now know that these are stress fractures. These atypical fractures are actually stress fractures. Sometimes people have bilateral symptoms and bilateral fractures. So again, what are they associated with? Vitamin D deficiency, rheumatoid arthritis, diabetes, and bisphosphonates and glucocorticoids. So take a look at your patients, look at them, talk to them, see if they've got this, because you can see on the x-ray, you can begin to see the stress fracture lines. You can see changes in the periosteal bone. And it fractures right along this site where there were changes. And so when the radiologist sees those, you can send them to the orthopedist and they rod those and they don't have the fracture. Okay, who can we stop and who do we have to continue with? This is the Flex Fit extension study data. It's all on alendronate, and the FDA looked at it and said, look, these are the people we can stop. If you have had no prevalent vertebral fractures, the only people that we need to keep, the only people we need to keep on bisphosphonate are the people with osteoporosis, okay? If you have no prevalent fractures, you've been on it for 3 to 5 years, then if your T-score is greater than -2.5, it's above -2.5, I can stop you. If you have had prevalent fractures, then if you still have osteoporosis, I need to keep you on it. If you're -2 to -2.5, I need to keep you on it. Otherwise, I can stop it. So that gives you a clue about who to stop. Now, the new data from zoledronic acid, these people looked at zoledronic acid, which used to be marketed as reclassed. Remember, now it's generic. So your patients had that for 3 years. They've had zoledronic acid for 3 years. We can take a look at them, and if their femoral neck T-score is above -2.5, so they don't have osteoporosis, they had no fractures when you began, they had no fractures during the 3 years, you can stop. Even if their T-score is -2.5 and they have osteoporosis, if they had no fractures baseline and no fractures during the study, you can stop. If they have above a T-score above -2.5, even if they've had a baseline fracture, they've had no fractures on the 3 years of zoledronic acid, you can stop. Any other combination, really not a good idea to stop, keep on. So I think this is nice new data, particularly with zoledronic acid that we use all the time in the office and people may be using outside for your patients. So when is the drug holiday over? We don't know. But we suggest you obtain DEXA scans yearly. If the insurance company gives you a hard time on the second year, you can obtain it every 2 years again. You're looking for big changes, and most scanners won't record them for about 2 years anyway. When you begin to get a significant decrease in bone mineral density, start something. You can start a bisphosphonate again. Bone destruction markers are expensive, and insurance companies don't pay for them, but they do change. They do go up before, as you start to lose bone again. So before the DEXA changes, the bone destruction markers go up. You can ask the insurance company, tell them you have a patient on a drug holiday. I haven't been refused yet for one of those when I did that. Okay, as we end up, how about teriparatide or Forteo? It's the only anabolic agent we have. It stimulates osteoblasts. It decreases spinal fractures. It's approved for 2 years of use because osteosarcoma was reported in rats. When are we going to use it? When the patient's been on bisphosphonates for too long, they still have osteoporosis, they're on their 5th year of zoledronic acid, you don't know what to do, you're going to use teriparatide. It's very expensive, has very few side effects. And the good news is they now have, 9-year, I think it's 9-year data, that they've never had an osteosarcoma in a human on teriparatide. So for 2 years, if you use it for 2 years, they've never reported an osteosarcoma in a human. So good news. Seems like rats are susceptible. And finally, there are going to be new drugs in the market. We talked about anti-sclerostin antibody last year. And now we're looking at cathepsin K inhibitors. What the heck is cathepsin K anyway? It's the primary osteoclast-produced. It's the enzyme that destroys bone. And now we can inhibit it. And a number of resourceful pharmaceutical companies are working on medications to inhibit it. So next year at this time, we may be talking about a brand new osteoporosis drug. You'll know more about that, Mark, than I, because you're on the committee, right? You know when it's going to, oh, good, we can ask him when it's going to come out. Anyway, okay, so that's it for osteoporosis. And we're going to switch over to cases, right? Okay, let me see. Oh, my goodness, there are a lot of